is the ninth National Online CMEs. The topic this time is tuberculosis. For those who are joining us for the first time, I'd like to remind them that these CMEs are held regularly and usually on the first Thursday of every month. We'll try to stick to the first Thursday deadline. The main purpose behind these CMEs is that the experience and expertise of the master teacher is made available even to the remotest clinician of our country. I take great pleasure in informing you that stalwarts of clinical medicine in India have very graciously accepted our request to be our guests of honor, chairpersons, moderators, and speakers for today's deliberation.
मैं
The
वहां गया
guests
था
of honors for today's program are Dr. K.K. Parikh sir and Dr. H.S. Pathak sir. Dr. K.K. Parikh sir knows no introduction at any forum. He is past President API, past Dean Indian College of Physicians, and the immediate past President of IACM. It was his idea to have these CMEs, and he is the heart and soul behind these CMEs. It is under his inspirational guidance and leadership that these CMEs take place. I would now request Dr. Parikh sir to bless us with his words of wisdom. Over to you, sir.
Thank you, Dr. MP Singh, for your kind words. Good evening, everybody. It's really a great pleasure and an honor for me to welcome our dynamic president, Dr. H.S. Pathak, who has taken over this year. And I'm so thankful to him that he has continued the same CME program, online CME program for all of us to dissemination of knowledge to everyone. I also welcome our meeting president and pillar of strength to our IACM, Dr. M.M. Singh, Professor M.M. Singh. Thank you so much, sir, for coming and to grace this occasion. I also welcome our chairperson, Dr. Ashok Shiromani, Vice President of IACM, and Dr. Gurvinder Mohan, the member governing body of IACM, and Professor A.S. Sachan, ex-principal and dean, Agra. We have got two very important learned speakers, faculty, Professor Sanjeev Sinha and Professor G.V. Singh, will be speaking on a very common topic of tuberculosis, which everybody knows what is the tuberculosis, how it spreads, and what is the treatment. But there are so much more to know about this dreaded disease. So I think it is the right time we can discuss about tuberculosis with the great faculties which we are having today. I would like to give and extend my sincere thanks to our convener, Dr. MP Singh, which has been, because of his the maximum and great efforts, dedicated efforts by him, that we are continuing these CME programs online, and the aim of our IACM, the disseminate the knowledge to everyone, is being fulfilled through these online CME. So I extend my sincere thanks to Dr. MP because of his hard work that we could be doing this program, such a wonderful and successful program. So thank you again, all delegates who are attending this today's online CME programs. Thank you very much. Yeah, IACM.
Thank you so much for your kind words. Dr. H.S. Pathak sir is traveling at the moment. He's unable to join due to some network issues. He'll be joining us in a few minutes. I take this opportunity to welcome our chairpersons, Dr. Ashok Shiromani sir, Dr. Gurinder Mohan sir. Dr. Ashok Shiromani sir was Honorable General Secretary of IACM and is the current Vice President of IACM. Dr. Gurinder Mohan is Professor and Head Department of Medicine in Medical College, Amritsar. He was also the organizing secretary of a much successful IMCon. He takes a very keen interest in all activities of IACM. It's a pleasure to have you with us, sir. I take great honor in welcoming Dr. A.S. Sachan sir as the moderators for today's evening.
Thank you, sir.
Sir has been professor and head Department of Tuberculosis and Chest Disease for almost 20 years. He was also the principal and dean of SN Medical College. Sir has been President, National College of Chest Physician. It is an absolute honor to have you with us, sir. With these words, I would now request the chairpersons, Dr. Ashok Shiromani, sir, and Dr. Gurinder Mohan, sir, to take over the proceedings. Over to you, Dr. Gurinder Mohan, sir.
Thank you, Dr. MP Singh. We are delighted to have to chair such a good session. I welcome Dr. Subhash Chandra Gupta, who is our immediate past president. And I welcome Dr. H.S. Pathak, who has just joined, and we'll be glad to know his views. Dr. Pathak, please.
Good evening, everybody.
Good evening, sir.
It's been my pleasure to. It's my pleasure to welcome our past president, Dr. K.K. Parikh, chairpersons, Dr. Ashok Srimani, Dr. Gurinder Mohan, and Professor A. Sasen. And everybody has been introduced by our convener, Dr. M.P. Singh. So let us proceed. Over to chairpersons, please.
I would like Dr. The first speaker to please give his talk and let us know more about the diagnosis and the latest ways of diagnosing tuberculosis, which he knows so well, and he's an expert on this.
I will request Dr. Gurinder Mohan, sir, to introduce Dr. Sanjeev Sinha, sir, who will then give his talk for around 25 minutes. Right.
Thank you.
Dr. Gurinder Mohan, sir, yes. Over to you, sir.
Hello, जी, sir. It's my honor. Hello, it's my honor to welcome for the speaker for today's talk. So, starting with the first talk of this session, on the topic of tuberculosis, about conventional and new diagnostic tests for tuberculosis, which to choose and how much to rely upon. Dr. Sinha, he is professor of medicine at AIIMS, New Delhi. So he has got numerous positions to his credits. He's member NCCP and ICS, member of ATS and member of ERS also. Sir is in charge of bronchoscopy and lab and chest clinic. He is professor in charge of HIV drug resistance lab and he's a member of ART clinic also. Sir has got numerous awards and achievements to his credit. So, without taking much of his the valuable time of the speakers, I will invite Dr. Sinha to kindly start with this.
Yeah. So, thank you very much, and good evening to everyone. At the outset, I would like to
Dr. Sinha, please.
Thanks Professor M.M. Singh, he is my teacher, and Professor M.P. Singh for inviting for this talk. And good evening to everyone, all seniors. Yeah, can you hear me? Yeah. Dr. Singh, can you hear me?
Yeah. Yes, sir, you are audible, sir. Thank you, sir.
Thanks, sir. Thank you. So, my today's talk is on conventional and new diagnostic tests for tuberculosis, which to choose and how much to rely. So I have been allotted to speak on a kind of diagnostic topic. I'll try to justice on this. And I have included both older form of diagnostic tests for diagnosis of tuberculosis and newer form of tests which are available at present and having very good sensitivity and specificity. So I'm going to start with microscopy. Then I'll come on molecular diagnostic test, culture methods, antigen detection test, and ADA. So if you see here, just starting with the sample collection. So how much sample we have to take for confirmation of tuberculosis sputum? So generally we take 2 samples in sputum, and each sample have to be 3 to 5 ml. Then cerebrospinal fluid, we take about 10 ml, and it should be minimum 2 to 3 ml. And regarding pleural, ascitic, and pericardial, we take about 10 to 15 ml. And if you want to do cytology, then we have to take 50 to 100 ml extra fluid. And urine, for urine, we take 10 to 15 ml and prefer up to 40 ml early, and it should be early morning sample. And for tissue and lymph node, we take as much as possible, add 2 to 3 ml sterile saline with the sample. So coming to the light microscopy, like how we do the staining and microscopy, that is old method, and we call it Jaden staining or Jean-Lanson staining. And you can see here, I'm not going in much detail. I'll just give brief overview because I have been allotted 25 minutes. So if you see here about regarding the procedure of Jaden staining, so there are 4 steps. Number 1, we apply primary stain to we just take the sputum on the slide and apply primary stain for about 30 seconds. And then step number 2, heat and fix the cells to slide using flame. And then we decolorize with acid alcohol for about 15 to 20 minutes. And then we apply counter stain of methyl blue for about 30 seconds. Then we rinse the slide with excess stain. So you can see here that we have kind of acid phos bacilli which are appearing in red in color. So this is the typical slide we see both in we teach our student also, and in microbiology and in medicine. So coming to the newer form of microscopy, that is called fluorescent light emitting diode or LED microscopy for diagnosis of tuberculosis. And this is recently introduced by WHO under WHO policy. WHO recommends that conventional fluorescent microscopy to be replaced by LED microscopy, and that LED microscopy be phased in as alternative for conventional Jaden light microscopy. It is more sensitive, it is less expensive and require less power and can run on batteries, and also its bulbs have long half-life. So there are many benefits, and you can see here like sensitivity is also high as compared to the light microscopy. Sensitivity versus culture is around 84%, and specificity is 98%, and for Jaden staining it is 6% more sensitivity, and for fluorescent it is 5% more sensitive and 1% more specificity. So you can see like there are many benefits of this instrument. So coming to the molecular diagnostic methods, which are very popular nowadays, and we have several molecular diagnostic tests at the recent time, starting from Gene Expert and Gene Expert Ultra. Then we have HTRSA, TrueNet, Gene Expert Omni, Line Probe SA, LAMP, and LAMP. So I'm just going to discuss briefly all these tests. And I would like to tell these tests are very helpful in diagnosis of tuberculosis, and also very helpful in the diagnosis of multi-drug resistant tuberculosis within 24 to 48 hours. So we can help to the patient for the starting the multi-drug resistant tuberculosis treatment as early as possible. So coming to Gene Expert RIF, this is a kind of cartridge-based nucleic acid amplification test or CBNAT to detect the Mycobacterium tuberculosis with resistance, and total duration of test of this test is about 2 hours. And it is available in the semi-quantitative or real-time methods, and the result is given in the semi-quantitative. The result is given in the form of high, medium, low, very low, depending on the CT value, and real-time the amplification detection at the time at the same time. So here, if you see here, we get the RPOB gene in this gene expert test when the patient is having RIF resistant. And there are 5 overlapping probes point to wild type of genes and do not point to the mutant sequence. And what happened, like you can see here, there are 5 probe A, B, C, D, and E. And we can have rifampicin resistant not detected when patient is having RIF sensitive, all 5 probes positive for the CT max, and the rifampicin resistant detected means any negative probe or CT max mode value will be more than 3.5 between any 2 probes. So this is kind of more of a for the hardcore microbiologists, but just brief overview I want to give how we interpret this RIF resistant. And this is a kind of machine you can see here. This is gene expert machine, and this is cartridge-based machine. So initial 2 step we do by hand, and starting from 3rd step, there is end of hands work, and all will be done inside the machine, including sample in the automatically filtered and washed, ultrasonic lysis of the filters captured organism to release DNA, and DNA molecules are mixed with dry PCR reagents, and then semi-nested real-time amplification and detection of integrated reaction. And finally, we'll get the printable report test result within 2 hours. So you can see here, this time to result is around 1 hour 45 minutes. And this is all cartridge-based molecular test. So coming to the, like this is a study done at our department at AIMS New Delhi. And AIMS is also intermediate referral center for the tuberculosis by CTT, Central TB Division. And we are getting samples from about 6 districts in Delhi. And you can see the publication on evaluating the diagnostic accuracy of expert MTB RIF assay in the pulmonary tuberculosis. And if patient is having all culture positive, then sensitivity is around 95.5, 95.7%. And smear negative culture positive, sensitivity is 77.7%. And when smear positive and both smear and culture are positive, then sensitivity is very high, almost 99%. And specificity is also high, it is 99.6%. Another study which was done at AIMS, and you can see here the same thing in extrapulmonary tuberculosis, and we found that high sensitivity, almost 97 to 98% in cold abscess, lymph node, and CSF. CSF is less, around 68%, and low sensitivity of gene expert in urine, endometrial fluid or aspirate, and pleural fluid, and pericardial and peritoneal fluid. So high sensitivity, number 1 in the cold abscess, in the pus, and followed by lymph node and CSF, and low sensitivity in the urine, pleural fluid, pericardial, and peritoneal fluid. So these are all data is available here. And specificity is also very high. It is around 97% to 100% in different kind of fluids. So I just so a brief case. There is a 25-year-old male. He came with history of productive cough for 5 months, with fever for 4 months and loss of weight and loss of appetite. And he visited to the hospital to physician, and the physician advised to do chest X-ray, and chest X-ray is showing cavity in the right upper lobe, and sputum was done, a sputum done for gene expert, and that is showing the positive for mycobacterium tuberculosis and RIF sensitive, rifampicin sensitive. And what will be the next step apart from starting drug sensitive tuberculosis management? So it has been seen when rifampicin resistant is detected, the patient is offered first line LPA, and drug sensitivity test. When rifampicin resistant is not detected, the patient is offered first line LPA for detecting resistance of the isoniazide. So, when based on the report, patient has been started on first line therapy, and after 6 weeks of antitubercle therapy, there was no improvement in his symptoms, and repeated X-ray is showing there is worsening of the lung picture. So what next to be done? So we have to see patient is having isoniazide monoresistance, other drug resistance. For that, we need to do either culture for midget culture, like liquid or solid culture, or we have to do first and second line LPA, and then other causes may be mutation outside the hotspot region, hetero resistance, desired therapeutic drug concentration not attained, and non-tubercular mycobacteria or NTM. So that could be other possibility. Because of that, patient is not responding. So we have to rule out other possibilities also. So coming to Gene Expert Ultra. So if you see here, like this is a kind of a new method, which is more sensitive than conventional Gene Expert. And you can see here that overall sensitivity is high in ultra, like 90.9% by ultra, while expert is having 84.7%. And in smear negative culture positive specimen, the sensitivity in ultra is 77.5%, and in expert 60.6%, and specificity is at 95.8% and 98%. And when patient is having RIFs sensitivity, then ultra is having 94.9% and expert is having 95.3% sensitivity. So you can see that ultra is better as compared to routine test. And here they have done like a study done by Silser et al., and they have shown that HIV positive patient, the sensitivity of ultra is high as compared to expert. Both sensitivity and sensitivity is high in patients who are having HIV positive. So coming to the TrueNet, I'll just give the brief overview. The TrueNet is another molecular test that help in diagnosis of mycobacterium tuberculosis. And this is chip-based real-time real-time PCR test for the semi-quantitative detection and diagnosis of mycobacterium tuberculosis complex bacteria. And there are 4 steps for diagnosis. A liquefied lysed sputum specimen has been taken, and then extracting the DNA from the sample and amplifying the extracted DNA and testing the amplified DNA. And what is the benefit of this machine? This kind of mobile unit or device run on the battery power up to the 10 hours, and target sequence is the NRD gene, which codes for the ribonucleosides diphosphate detectors large subunit and can be cost effective in density. So this is, you can see here, this is the TrueNet extractor, and we have other like buffer solution, and it is a chip-based instrument. So you can see here chip also, and reports we can get within 2 to 3 hours. And it is one more important thing, it is less cost effective as compared to routine expert or ultra. So another very important instrument that is molecular based called Gene Expert Omni, and this is a portable instrument, and it is battery operated single module or single cartridge instrument, and which enable the expert technologies to reach the primary health center. So when this is kind of a mobile unit, we can take it in the remote area where we can operate it on the battery, and there are dramatically reduced time to diagnosis for the many patient and facilitate the switch from the far less sensitive smell microscopy with rift resistant detection, not suitable for the clinic with a high attendance of patients. So this is a kind of unit that is also available in the remote area and help with the diagnosis of rift resistance. Another recent gene expert that is called extensive drug resistant gene expert XTR, and this is rapid automated net of low complexity. It in a single test detects mycobacterium tuberculosis complex, DNA and mutation associated with resistance to isoniazid, fluoroquinones, second line injectable drugs like amikacin, kanamycin, and ethanamide, and it is designed as a reflex test. So this is also like a very important instrument, and you can see here the sensitivity is around 94.2% in isoniazid, and in fluoroquinol is about 93%, and ethanamide 98%, and for injectable like amikacin it is 86%. So coming to another important molecular test, that is line probe assay or LPA. This is molecular based test on DNA hybridization assay who detects Mycobacterium tuberculosis and resistance to the first line and second line drugs, first and second line anti-tubercular drugs. It is like results come within 72 hours compared to culture-based drug sensitivity tests. And first line LPA detects Mycobacterium tuberculosis complex and resistant to INH and rifampicin. And second line LPA detects Mycobacterium complex as well as resistant to fluoroquinones and second line injectable drugs. So coming to the culture methods, we have two types of culture method. Number one is solid media or LJ media, and we have liquid media or widget test also. So this is like LJ media is egg-based test, and this is selective, like malachite green inhibits growth of contaminating bacteria and fungi, and shelf life of the test is 6 to 12 months when refrigerated. So you can see here, this is the green color tubes and then other tubes and plates which we use as a solid media. And the advantage of this test is contamination rate is low, and disadvantages require an average of 3 to 4 weeks to recover mycobacteria from clinical specimens. So coming to the liquid test or midget, and this is also very important test, and it is gold standard test nowadays for culture, liquid culture, and it is recommended standard practice of mycobacteriology laboratories. Advantages are increased recovery of mycobacteria, decreased time of detection compared to solid media, and some mycobacteria grow only in the liquid media, and disadvantages contamination rate is very high. So another new test, that is antigen testing or Kepler-B assay. This is an antigen-based test. It detects Mycobacterium MPB and MPT64 antigen secreted by Mycobacterium tuberculosis complex, and is based on the lateral flow immunochromatographic assay and differentiate between Mycobacterium tuberculosis complex and antium. And this is rapid, simple, and low cost treatment. And you can see here that we take the sputum AB smear positive or negative samples, and then who comes the sputum culture positive, we do this test, and if and we can detect both MTB and antium. So this is also available nowadays, and you can see this is available in the kit format, and it is a kind of rapid test. So another important test that is recently recommended by WHO, and this is lateral flow urine like LAM test, and LAM is present in the mycobacterial cell walls released from the metabolically active degenerated bacterial cells during TB disease. The currently available urinary LAM assay have suboptimal sensitivity and are therefore not suited for the general diagnostic test for tuberculosis. However, unlike traditional diagnostic methods, they demonstrate improved sensitivity for the diagnosis of tuberculosis among individuals who infected with HIV. So it is more, you can see here, as per WHO recommendation, we use LAM to assist the diagnosis of TB in HIV positive patient. And you can see here that with signs of TB, its sensitivity is 42%, and advanced HIV disease or CSL, we have sensitivity 35.5%, with specialty is 95%. And patients who are having like HIV positive patient who have CD4 count less than 200 inpatient and less than 100 outpatient, the sensitivity is 26% and 47%, with specificity between 96 to 90%. Another very important test, that is ADA. This is kind of very old test, and it have very important value in the diagnosis of pleural fluid tuberculosis and ascitic and CSF. And you can see here, like ADA cutoff value is 35 in pleural fluid tuberculosis, and in ascitic fluid it is 30, and CSF it is 6, and pericardial fluid it is 40. And sensitivity is good in pleural fluid. It is one of the study done by Dr. Sharma at AIMS New Delhi shows 83%, and the study done by Dr. Agrawal in 2014 that is showing 94%. And the specificity is between 66 to 89%. And in ascitic fluid, the sensitivity is good. It is 93%, and same in the CSF. Sensitivity is 75%, and in pericardial fluid, the sensitivity is 84%. So I have a few, 2-3 more slides. So if you can see here the time yield or lower limit of detection of bacteria. So the ZN staining microscopy take about 45 minutes, and LED microscopy takes 30 minutes, and solid culture LJ media takes 8 weeks. Solid culture DST takes another 6 weeks, and liquid culture Megit and 960 and 960 takes 42 days, and liquid culture DST magic takes about 13 days, 2 weeks, about 2 weeks, and then ICA test take 15 minutes, and line probe assay takes about 2 to 3 days, and gene expert takes 90 minutes. So this is a different timeline, and you can see here that a gene expert and new method like new molecular method, gene expert takes 90 minutes, and our old method, that is ZM staining microscopy, takes for AFP positivity about 45 minutes. And by newer microscopies takes around 30 minutes. So as I said previously, that gold standard for MTB culture is liquid culture, and for drug sensitivity test is solid culture. So coming to the conclusion, Expert Ultra has a much higher sensitivity for the detection of MTB complex, especially in the smear negative culture positive tuberculosis as compared to Expert. TrueNet is an developed molecular assay with comparable diagnostic accuracy as compared to Expert MTB RIF, with the added advantage of being battery operated. And first line LPA has to be sent for all patients who are positive for the molecular method, irrespective of drug resistant status. And with increasing resistance of isoniazid and fluoroquinolones, newer modalities like Expert XTR offer hope for guidance of therapy in the future. Thank you very much.
Thank you very much, Dr. Sena, for
Yeah,
very
thanks, sir.
crisp and concise talk.
Thanks.
I think we can take up the questions from the delegates at the end of the session total.
Dr. Sanjeev Sinha has some other engagement. If the questions, if there are any, should be taken at this point of time.
Okay, right. Sir.
Thanks.
I want to ask a question from Dr. Sinha.
Yes, sir.
All said and done, are these tests, the high-end tests, cost effective?
Yeah, yes, sir. Iron test, just as I mentioned in beginning, that tests like these kind of tests like Gene Expert and Gene Expert Ultra. So Gene Expert is available under national program, and if you go in the government hospital, then it is free of cost for a patient. Otherwise, if you do in the private setup, it is cost is around like 1,000 rupees per test. So definitely the cost is high, but TrueNet is, as compared to the Gene Expert, TrueNet is less. It is costing around 600.
TrueNet is available in government hospitals also.
So government hospital Gene Expert is mainly available, but now government is I think supply. I'm not sure. I'm sure about Gene Expert because it is available in our hospital. TrueNet is basically available in the private setup and under research program also.
I'm Dr. Ghosh. Can I make one question to Dr. Sanjeev Sinha?
Yes, sir, please.
Sure.
Yes. You have given the CSA value of ADA in tuberculosis as 6, I think, so far I can recollect.
Yes, sir. Yes, sir.
Some of the books they're telling 10, 11, and some of them are not at all relying on that. They are more in favor of PCR, TB PCR from the CSF.
Yes, sir.
Any idea? Can you just clarify the issue?
So you are talking about AD, sir? AD?
ADA and CSF versus TB PCR, and value of 6. Some books it has been, in fact, Dr.
Yes, sir. Yes, sir. I got your point.
They have sent
this I have taken.
10 to 11 and
Yes,
yes.
Yes, yes. I got your question. I have given the reference also. I have taken this from Ghosh et al. That article was published in 2016, And they have mentioned then CSF sensitivity is around, cutoff value is 6 and sensitivity is around 75%. So as compared to the pleural fluid, sensitivity is low in the CSF. But definitely there is a role. We do ADA test because you see, gene expert is also not very effective. The sensitivity is low in in CSF fluid. So people are doing PCR test also. That is also very helpful. In our neurology department at AIMS, they do prefer PCR test. And they do ADA also. And in addition to that, they are doing gene expert also. So I agree with you.
Is there any specific indication for doing, I mean, this line probe assay in patients of tuberculosis? Is the specific indication or?
Sir, I mentioned that this is like first line LPA has to be sent in all patients who are positive by a molecular matter, irrespective of drug resistance. So what is happening, like I have mentioned the case report, one of the case also, that case was RIF sensitive, but he was not responding to the treatment for about 6 weeks. And in fact, a repeated X-ray showing there is enlargement of the cavity. So that's why we are doing LPA, first line LPA in all the patients who are having AFB positive. If AFB is negative, we don't do first line LPA. So that helps in diagnosis of like isoniazide. It gives the result both for rifampicin and isoniazide resistance. So if patient is having isoniazide resistance, then we have to change the treatment.
Okay.
Otherwise, patient will not respond to the treatment.
My last question is about tuberculosis treatment of the bone, joints, and I mean CNS. Some of the neurosurgeons, particularly and orthopedician, continue anti-tubercular drugs for months together, if not year, 1.5 year, 2 years after diagnosis, the tuberculosis of bone, joints, and particularly CNS. What's your idea? Should we continue that? Is there any guidelines? Is it different from?
Yeah, definitely. Recently, we have 6 days CME on extrapyramidal tuberculosis. We have made the national guideline for nasal tuberculosis intervention program, and that is showing like extrapyramidal tuberculosis. We call this index TB guideline. And index TB guide, according to the index TB guideline, minimum treatment for CNS TB is 1 year, and this physician decision or radiological changes, radiological improvement is not there, like you do MRI, and there is not improvement as compared to the baseline of 6 months MRI. So we can extend the treatment. And if patient is symptomatic, then we have to extend the treatment. But in index TB guideline, they have mentioned that 1 year treatment is enough. If patient responded and radiological improvement is there, then we can stop after 1 year. If patient is totally physician's decision, treating physician decision. If patient is not responding in 1 year, then we have to extend the treatment. This is also mentioned in the index TB guideline.
May I have
Yes,
the
sir.
recommended duration of treatment for extrapulmonary tuberculosis like CNS and osteoarticular tuberculosis should be preferably a minimum of 9 months to 12 months.
Yes.
That has been recommended.
Yes. Thanks.
Dr. Sinha, I am Dr. Vikas Numba from Ludhiana. I had a small query.
Yes.
In AIMS or other referral centers, are you following these protocols, or you're just gene expert and you're extra gene and all these? Are you doing these, or this is on a research basis only?
So, expert MTB RIF is available in all over country, and this is under CTT program. So sometimes cartridges are not available, but we follow, like we do routinely expert under national program in our practice also. And other tests, like I mentioned, ultra and some more tests, these are under research more of under research, but in future, we may get under national program. They are also available in the private sector.
Dr. Parsunani from Agra, I want to ask
Sir,
for
no,
the
sir.
urinary tuberculosis,
Yes, sir.
what to do?
Sir,
Diagnosis.
Right, sir. Thank you, sir. So for urinary tuberculosis, we have to do urinary, like if any patient is coming with symptoms of urinary tuberculosis, so we have to do first AFB, and as we know that sensitivity of expert is low in the urine test. So recently WHO have recommended the LAM test for diagnosis, but it is more, I mean, yield is better in the HIV positive patient. So we have to do AFB test, gene expert test, and culture for AFB. That is the main say. And recently, LAM is also coming up. Some reports are available that shows it is good in the urine TB.
Okay.
Hope there are no other questions. I think most of the things have been clarified by Dr. Sinha.
Yes, sir.
So that's fine, sir. Thank you so much, Dr. Sinha, for this very crisp and talk. I think the queries of the audience, they have been clarified by now.
Okay.
Thank you,
very
sir.
much.
It was
sir.
a very
Thank you.
difficult topic and it has been dealt with very beautifully and expertly by you. I hope everybody must have benefit. Thank you for sparing your time, sir. It was an honor to have you with us.
Thank you very much, sir. Thanks for invitation. And my regards to it. Thank you.
Thank you.
Thank you, sir.
Thanks.
It's all right. Just complete the modalities of investigations apart from confirming the bacteriological diagnosis. Other important aspects, other parameters are imaging techniques. Imaging, radiography, everybody knows. And CT, there is a definite role of CT or HRCT in the pulmonary as well as extrapulmonary tuberculosis. Sonography, MRI is more helpful in extrapulmonary tuberculosis other than tuberculosis, pulmonary tuberculosis, and the very recent optical coherence tomography, which is very often used by ophthalmologists, OCT, eyeball. It predicts all the layers of eyeball very well. And another advancement in the imaging techniques is confocal imaging by depicts the histology, even including biopsy, optical histology, which reflects the actual position of all the details of cells. So these are very, very important newer methodologies, newer techniques, which depicts and confirms the diagnosis very, very easily. About the biomarkers, when we are not able to confirm by all these modalities, particularly in extrapulmonary tuberculosis, so like adenosine deaminase and gamma release assays are important. These are the markers, sero markers, which help to support the diagnosis of tuberculosis. Another important point is when we are dealing with moderate, minimal or moderate disease with sensitive bacilli not responding, remains stationary, the disease is neither increasing nor decreasing radiologically in subsequent X-rays. The possibility of mycobacteria other than tuberculosis has to be kept in mind. Sometimes we come across with these non-tubercular mycobacteria. Rest all has been done very nicely by Dr. Sinha. So imaging techniques, and last but not the least, endoscopic procedures which are helpful in diagnosis as well as sometimes for therapeutic purposes as well. So endoscopy is another modality which is very, very important in management of pulmonary as well as extrapulmonary. Endoscopy is right starting from the bronchoscopy and bronchoscopy, esophagoscopy, and for laparoscopy, cystoscopy, and hysteroscopy, which includes all the abdominal tuberculosis. Thank you.
Thank you, sir.
Thanks.
Lightning words. I would now request our chairperson, Dr. Shiromani sir, to introduce our next speaker, Professor Dr. G.V. Singh sir. I think there have been some network issues with Dr. Shiromani sir. I would now request Professor G.V. Singh sir to start with his lecture, Management of Extrapulmonary Tuberculosis. We welcome you, sir. It's an honor to have you with us.
Very good evening to all of you. I'm grateful to the leadership of Indian Academy of Clinical Medicine for giving me this opportunity to interact with this learned audience. I would like to thank the leadership again because they have chosen a very important topic, that is the tuberculosis, management of tuberculosis. Much of the task has been done by Dr. Sinha sir, and I have given the responsibility to talk about the management of extrapulmonary tuberculosis. You know, tuberculosis is an ancient disease. We also know that tuberculosis is caused by the Mycobacterium tuberculosis, and it is an infectious disease caused by the Mycobacterium tuberculosis complex. Because it's spread by the airborne particles, by droplet nuclei. These are the droplet nuclei which are responsible for the spread of the infection. Around 1/4 of the bird population is infected with the Mycobacterium tuberculosis. And very unique socio-demographic situation of India. Around 40% of the Indian population is infected with the Mycobacterium tuberculosis. If we look at the natural history of the tuberculosis, so once there is a breach in the immunity of the patient, of a person, the TB infections are converted into the TB disease. We all know, and we have also know that's around 5 to 10% of the infected person will develop active TB disease in their lifetime, and around most of them, up to the 90%, they develop the disease in the first 2 years of their getting the infections. When you look at the natural history of the tuberculosis, you will find that the case fatality rate of the tuberculosis is around 74%. And that is why when there was no treatment available to manage the tuberculosis before the era of anti-TB treatment development, this disease was responsible for death of approximately 1 billion people only in 2 centuries, that is from 17 to 19, and that's why it was called as the white plague. But over the last 6 decades, the treatment of tuberculosis has significantly improved. TB is now considered as a curable disease provided it is being treated as per the standards of the TB cure. So through effective prevention and diagnosis, the burden of tuberculosis has decreased. We have achieved the goals of the Millennium Development Goal. Now we are moving towards the Sustainable Development Goal, and from the Stop TB strategy to End TB strategy. If you look at the progress of the End TB strategy, the progress is not satisfactory. We have achieved only around 9% in the reduction of the incident rate against the 50%, which is our target. And like this number of deaths, we have achieved only 90% reduction in TB deaths. Again, the 75% of the milestones, and again, the catastrophic cost, that is the out-of-pocket expenditure by the patient, we have achieved only 49%. Again, it should be the 0%. So current progress is not satisfactory. So there are some obstacles on the path of NTB strategy. What are these obstacles? There is gaps in the TB diagnosis and treatment. There are growing crises of drug-resistant tuberculosis. This is again a big problem. And there is a deficit in the TB preventive services, at least to treat latent TB infection. And there is a funding gaps in the TB research, diagnosis, and treatment. And lastly, I can say the management of extrapulmonary tuberculosis is still challenging. We face lots of problems while managing the cases of extrapulmonary tuberculosis. We also know that in most of the cases, in around 85 to 70, 80 to 85% of the cases, lung is the primary site of involvement. But in around 10 to 15% of the cases, in immunocompetent patient, the extrapulmonary site can be involved. But in immunocompromised patient, like the HIV infected patient or other immunocompromised states, other sites are very, very common along with the pulmonary. So in HIV positive patients, in around both pulmonary as well as extrapulmonary sites are very, very common. There are certain critical issues in the management of the pulmonary, extrapulmonary tuberculosis, because it is a bacillary disease and it is very difficult to take the sample for microbiological confirmation. So that is again an issue. So extrapulmonary TB is usually underdiagnosed and undertreated with the poor compliance of the treatment. So this is a very big issue. And there is an underuse of the molecular tools for the early diagnosis of extrapulmonary TB. There are availability of the various molecular tools for very long time in the country. Despite of this, the doctors and treating physicians, they are not using to diagnose the extrapulmonary TB. And beside this, there is no uniform policy, national policy for the management of the extrapulmonary TB. And there are issues like empirical treatment of extrapulmonary TB. What should be the role of tubercular skin test? What should be the duration of treatment for extrapulmonary TB? What should be the role of steroid in extrapulmonary TB and diagnosis of TB in people living with the HIV, and diagnosis and management of the paradoxical reaction, which is usually seen in the extrapulmonary TB, especially in HIV infected patient, and surgical management of the extrapulmonary TB. Besides this, we have new national TB targets. So we have to achieve the goals, the targets, of TB strategy, not in 2020, but 5 years ahead, as per the base of our respected Prime Minister by 2025. So we have revised this strategy, as mentioned by Dr. Sinha sir, that they have formulated the index TB guidelines, and very recently a training was conducted for all the faculty members. There were so many faculty members from all across the country. They participated in this training program, that is for the training module on the extrapulmonary tuberculosis last month in AIMS. So management of tuberculosis, as we know, they're divided into three important aspects. That is the diagnosis, second is the treatment, and third is also prevention. So for these all purposes, so according to the National Strategic Plan, a revised EPTB management strategy and algorithm was introduced. So just to summarize all these revised strategy, I have tried to make these slides like the diagnosis, various diagnostic modalities in extrapulmonary TB. So as mentioned by Dr. Sachan sir, beside microbiological diagnosis, radiological diagnostic modalities are important. Yes, definitely. And after radiological, microbiological diagnosis is required. Histopathological diagnosis is also sometimes done to diagnose your patients of extrapulmonary TB. And there are some supportive investigation like the markers for diagnosing these cases. So as far as the rule of diagnosing the extrapulmonary TB, the first rule of TB diagnosis is think of the TB. High index of suspicion in your extrapulmonary cases is very of paramount importance. So until unless you do not have the high index of suspicion, you do not think that this patient may be a case of, or this pathology can be because of the tuberculosis, you will not be proceed towards diagnosing the cases of tuberculosis. And include TB in the differential diagnosis when symptoms and signs are consistent with the TB diagnosis. So that is called as the presumptive extrapulmonary TB diagnosis. So high index of suspicion and followed by the presumptive extrapulmonary TB diagnosis is the third important part of diagnostic step. Recommend appropriate diagnostic tests to prove the infection. The most important one is the microbiological diagnosis. So this is third important steps in making the diagnosis of EPTB. Thereafter, another important steps come. So once you have presumed that extrapulmonary TB is, this case may be the extrapulmonary TB, you will not stop there and you will not rush to the starting the treatment. You will try your hard to make it microbiological diagnosis. And thereafter, after microbiological diagnosis, you have to do the universal drug susceptibility testing. Because without my universal drug susceptibility testing, it is very, very impossible. That's just impossible to diagnose the drug-resistant cases. So UDST is a very important steps in the diagnosis of extrapulmonary TB as well as pulmonary TB. And thereafter, cascading to detect additional drug resistance and susceptibility. We have the mechanism in the national programs that along with the CBNAT, we send the second sample for the first line probe assay or the second line probe assay to detect additional drug resistance. And second, some sample is also subjected for the liquid culture and thereafter for drug sensitivity. So these are the important steps in the diagnosis of tuberculosis. Thereafter, each and every case of EPTB diagnosed, they must be reported to the local public health authorities, which is we call notification. Because the notification give opportunity to support the patient in the terms of adherence support, blood sugar testing, counseling of the patient and family member, drug susceptibility testing, follow-up, HIV testing, intolerance of drug, ADR management, and justification of the management, and keeps reporting in the treatment outcomes. Like the presumptive pulmonary TB, presumptive extrapulmonary TB is the presence of organ-specific symptom and signs like swelling of the lymph nodes, pain and swelling in the joints, knee stiffness, disorientation, recurrent UTI. And beside this, constitutional symptoms like significant weight loss, persistent fever for more than 2 weeks of duration, and night sweats are important for presuming that this case may be the case of TB. And thereafter, the second step is the microbiological confirmation for all patients, whether they are adolescent or children with presumptive pulmonary or extrapulmonary TB. Appropriate specimens from the presumed site of involvement must be obtained to identify the causative agent of the disease. And the same specimens can be divided into two important categories, like the specimens not collected aseptically, like the sputum, gastric lavas, bronchial washing, pus, stool, and urine, and aseptically collected specimens like the various fluids, the CSF, pleural, pericardial, ascitic, and synovial. Sometimes we take the bone marrow for diagnosing the TB, tissues like lymph nodes and tissue biopsies, and fine needle aspirates, and sometimes blood. And the acceptable method for the microbiological diagnosis, as said by Dr. Sinha sir, but there are three important categories like the microscopy. In microscopy, again, two important methods, that Jordan staining and fluorescent staining. Culture, again, solid and liquid culture. And now it is very clear that the liquid culture, NIST 960 is the gold standard. And the rapid molecular diagnostic tests, these are the CBNAT and the line probe assay, first or second line probe assay. And we look at the sensitivity and specificity in the extrapulmonary sample. The sensitivity and specificity very, very excellent, except the pleural effusion. They are more than 75% or 80%. Though sensitivity and specificity is very, very slightly less in cases of the other fluid sample like the pericardial, ascitic, and synovial, but in other samples, the sensitivity is very, very wonderful. Around, again, third important step is the universal drug susceptibility testing, because there are so many reports that suggest that throughout the globe, around 70% of the patients of drug-resistant tuberculosis remains undetected. So despite of without doing the test for detecting the drug resistance, we cannot diagnose, because drug resistance is not a clinical diagnosis. It is not a radiological diagnosis. It is a laboratory diagnosis. So without doing these tests, it is impossible to know whether your patient is resistant to rifampicin or other drugs or not. So for UDST in the national program, there are two important and simple tests. One is expert MTB, which is called as CBNAT, and the second is the TrueNAT, that is a point of care test, and that has been explained in detail by Sinha sir. I'm not going details. And as mentioned earlier, there is cascading to detect additional drug resistance. So once there is a rifampicin resistance, so simultaneously once laboratory detect there is a rifampicin resistance, so second sample will be subjected for the first and second line and probability to know whether H resistance is there or not, or whether fluoroquinolone resistance and second line injectable resistance is there or not. If the patient is not resistant to the rifampicin CBNAT, then we use the first line probability to know whether H resistance is there or not. So this is the simple cascading to detect additional resistance. The second important thing which I can say, that is the imaging modalities. So X-rays and sometimes computerized tomography, ultrasonography, MRIs, and positive PET scanning are used to diagnose the extrapulmonary cases. There are again important issues which are most of the time asked by the physicians. What is the role of chest X-ray in diagnosing the extrapulmonary TB? Diagnosing the pulmonary TB by chest X-ray is controversial because the sensitivity is not is very, very excellent, but the specificity is around 50%. But if we talk about the use of chest X-ray in extrapulmonary TB, it is again shown in many studies that around 10 to 50% of extrapulmonary TB patients have concomitant pulmonary involvement. So once you find that your patient is also having the pulmonary TB, so taking of the sample will be very easy and the diagnosis will be very easy. And third, definitely the histopathological diagnosis, for which we use the excisional biopsy and or the punch biopsy. There are again certain issues that suggest, and they are usually asked by the physicians and surgeons, what is the role of the tuberculin skin test and the interferon gamma release assay? So again, I can say there are some limitations of if you look at these tests, the pooled sensitivity of interferon gamma release assay in diagnosing the active tuberculosis is not good, and specificity is again not good. So on the basis of these findings, WHO recommend that these tests should not be used to diagnose active tuberculosis. Actually, these both tests are used to diagnose the TB infections only. So, and sometimes in pediatric tuberculosis, they can be taken for the help of for making the diagnosis of active tuberculosis. But overall, these tests are not meant for the making the diagnosis of extrapulmonary or active tuberculosis. And this is a simple algorithm with the help of which we can make the diagnosis, like the presumed extrapulmonary TB, take the appropriate specimens from the site. If it is available, then go for the CBNAT. If MTB detected, then go for the again, there will be two types of the test results, whether it is rifampicin sensitive. I mean, it is rifampicin sensitive, it is microbiologically confirmed extrapulmonary TB, and the second sample will be subjected for the first line and probasive. And if the samples is not available from the site, then in high clinical suspicion is there, use other diagnostic tools like the radiology or other methods, histopathology, and then you make a diagnosis as a clinically diagnosed extrapulmonary TB, or you can think for the alternative diagnosis. This is again a simple algorithm for lymph node tuberculosis, because the lymph node tuberculosis is the most common form of the EPTB in India, accounting for around 35% of the extrapulmonary tuberculosis. And as mentioned by Dr. Sinha sir, index TB guideline, as well as in the module for the EPTB training, the diagnosis of the various extrapulmonary TB are very well mentioned, and they are available on the site of the Government of India Center TB Division. Thereafter come to the treatment of the tuberculosis. The aim of the treatment usually in tuberculosis is to cure the individual patient and minimize risk of death and the disability. And objective are to render the patient non-infectious and to break the chain of transmission and decrease pool of infection. But in extrapulmonary TB, this is not the issue, because these are non-infectious patients, and until unless they have the concomitant pulmonary involvement. And second important objective is to prevent the emergence of the drug-resistant mutant strains, for which multiple drugs with proven TST or likely, or we can say which they were never been used previously, and efficacy to prevent the selection of the drug-resistant mutants are used, and relapse-free cure should be there. So for which treatment is prescribed for a sufficiently long duration with monitoring of adherence to the treatment to eliminate residual surviving organisms that are responsible for the disease relapse. And for the management of this these TB patients, we use the multi-drug therapy, for which we usually use 4 TB drugs, to which Mycobacterium tuberculosis is known or likely to be susceptible in anti-TB regimen for adequate duration. So again, treatment depends. After the diagnosis and microbiological confirmation, UDST, you will have two types of the patients, whether they are microbiologically confirmed or not, whether it is drug resistant or drug sensitive, and accordingly you have to choose the regimens, whether you have to give the regimen for the drug sensitive TB or you have to give the regimens for the drug resistant TB. And again, in the drug sensitive and drug resistant TB, there are 2 phases, that is the intensive phase and the continuation phase. The purpose of the intensive phase to make the patient non-infectious, and the continuation phase just to prevent the relapse and achieving the principles of the cure. And regimens and duration of anti-TB depends on the resistance patterns, as mentioned earlier. And treatment of the drug-sensitive TB, it is very simple treatment. It is short again, and it is very economic, and less adverse reactions are there, and it is more efficacious. In which we use the 4 drugs, usually isoniazid, rifampicin, paracetamol, and ethambutol in these prescribed doses. And there are 2 phases. Intensive phase, continuation phase. So in intensive phase, there are 4 drugs. That is for the 2 ones. And then the continuation phase, we use the 3 drugs, the rifampicin, isoniazid, and ethambutol. And the drugs are given daily. There is no need for extension of the intensive phase, but the continuation phase may be extended by 12 to 24 weeks in certain form of the TB, like the CNS TB, skeletal TB, disseminated TB, and based on the clinical decision of the treating physician. Again, debatable question is the duration of treatment in the extrapulmonary TB. As mentioned earlier by Dr. Sinha sir and Dr. Sachan sir, in most of the cases of the extrapulmonary TB, 6-month duration of treatment is more than sufficient. But in certain cases, when the physician thinks that the extension of the continuation phase is required, you can give. But tubercular meningitis and skeletal tuberculosis, there is usually the duration of treatment is slightly long. In tubercular meningitis, treated with, there is an intensive phase with 4 drugs for the 2 months, and followed by the continuation phase, which consists of 3 drugs for 8 to 10 months. Like this skeletal TB, intensive phase is again for 2 months, that is for with 4 drugs, followed by a continuation phase, which consists of the 3 drugs. That should be at least for the 12 months and can be extended up to the 18 months on the case by case basis. In cutaneous TB, again, the 6-month TB is duration is required. If we talk about the treatment of the drug-resistant tuberculosis, treatment of Drug-resistant TB involves the use of multiple second-line drugs that are less efficacious than the first-line drugs. They are more expensive and have more adverse effects, making tolerance and treatment adherence very challenging. And the recommended regimens to manage DRTB are at present 3. One is for the H. monoresistant TB, and second one is the shorter oral bedaquiline containing DRTB regimen, and third is the longer oral regimen that is for the MDR or the pre-XDR or XDR tuberculosis. In H. monoresistant regimen, that is the extrapulmonary cases or pulmonary cases in which the samples, the isolates, or I can say the samples are resistant to isoniazid only. So we replace the isoniazid with the levofloxacin drug. There is no continuation, there is no separate phase, intensive and continuation phase. We give the levofloxacin for entire 6 months, or this can be extended up to the 9 months. There is another regimen that is the shorter oral bedaquiline regimens that is based on the, and we select the this regimen on the basis of DST patterns, whether the rifampicin resistance detected or inferred, or what is the situation of mutation in for isoniazid, like the both INHA mutation is present, or INHA and CATG mutation is present, or either INHA or mutation is present. Besides this other inclusion criteria, if there is a severe extrapulmonary TB, so this regimen is contraindicated, and even in women who are not pregnant or lactating, we should not use. And there are 7 important drugs which are used in these shorter regimens. That is bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, and high-dose isoniazid and ethanamide for a period of 4 to 6 months. And we give the bedaquiline for the 4 to 6 months. And thereafter, there is a continuation phase for 5 months. That is for the levofloxacin, clofazimine, pyrazinamide, and ethambutol. The longer regimen, which is used for the MDR or pre-XDR or XDR tuberculosis, they consist of the 5 drugs. That is the levofloxacin and bedaquiline, linezolid, clofazimine, and cycloserine. And the duration is for 18 to 20 months, depending on the type of the TB patient. Whether if they are XDR, then we give for the 20 month. Otherwise, in cases of the MDR, 18-month treatment is sufficient, more than sufficient. Another issue which usually come with the extrapulmonary TB is the recommendations for the use of steroid in the APTB cases. So there are 4 important indications where steroid has been should be given, like the tubercular meningitis, TB pericarditis, pleural TB, and managing the paradoxical reaction, the extrapulmonary TB. So there are again recommendations that in TB meningitis, steroids are recommended for the TB meningitis in HIV negative people. Duration of steroid treatment should be at least for 4 weeks with tapering as appropriate. Steroids may be used for TB meningitis in HIV positive people where other life-threatening opportunistic infections are absent. In cases of the TB pericarditis, steroids are recommended for the HIV negative patient with the TB pericarditis with pericardial effusion. These are the conditional recommendations, and steroids are recommended for HIV positive patient with the TB pericarditis with the pericardial effusion. And the conditions, low quality evidences are there. In pleural TB, steroids are not routinely recommended in the pleural TB. There are again conditional use for the steroid in the pleural TB, and there are very low quality of evidences for use of the steroid. But in managing the paradoxical reaction, there's the recommendation where the use of the steroid for a period of 15 days is usually required to manage it. So for me, I can say the tubercular meningitis, tubercular pericarditis, and the managing paradoxical reaction, and the 4th other indication, that is the any form of the TB, the pulmonary or extrapulmonary with the respiratory failure or very low general condition, you should start the anti-TB drug along with the with steroid. Surgical intervention. If we talk about the surgical intervention in extrapulmonary TB, again in TB lymphadenitis, if clinical symptoms do not improve, ESR or CRP is still high after the full dose of the anti-TB drug, and patient can be considered for the surgical procedure like the block resection, incision, and drainage. In pericardial tuberculosis, if even after giving the ATT plus steroid, response doesn't come at the 11th week, we need to refer the patient for the pericardiectomy to send the pericardial tissue for CBNAT and AFB and histopathology. In pleural TB, if the facility for pleural biopsy is not available and diagnosis is not made after the thoracoscopy, we can refer the patient to higher center for the pleural cyst. Chest tube drainage and video-assisted thoracoscopic surgery and thoracoscopy followed by the chemical and mechanical fluorisis can be done in the recurrent pleural effusion. And various cerebrospinal fluid diversion procedures, endoscopic third ventriculectomy and the shunt surgeries are performed for the management of the hydrocephalus associated with the tubercular bacterial meningitis. If we talk about the elimination of tuberculosis, look at this graph. It is impossible to achieve the targets of NTB strategy by 2025. There is the provision of tuberculosis preventive therapy that will bring down this decline. At present, the decline rate is at the rate of around 2.5%, and we have to achieve the decline rate in incident around 10%, and that can be possible with the help of the tuberculosis preventive therapy. So National Strategic Plan proposed the detect, treat, prevention, and build approach, and prevention of TB disease by treatment of latent TB is a crucial component of NSP, and targeted population for there is a targeted population for providing the tuberculosis preventive therapy in cases of the especially the pulmonary cases. And these are the people living with the HIV/AIDS, all household contact of the pulmonary TB patient, and expansion to the other risk group like the patient on the steroids, the patients, silicosis patients like so. And usually we give 6 months of isoniazid for these patients. So not only diagnosing and treating the extrapulmonary TB, but providing the provision of tuberculosis preventive therapy is also required to achieve the goal of the NTB targets. So summarize my talk, I can say all efforts should be made to obtain a microbiological confirmation among presumed patients of extrapulmonary TB. Preferred first diagnostic test for extrapulmonary TB is CBNAT. All patients with a diagnosis of PPTB should be risk assessed for the drug resistance prior to starting the treatment. All patients should receive an appropriate standard treatment regimen according to the drug resistance profile. And the 6 months of treatment is adequate in most cases of the extrapulmonary TB, and notify extrapulmonary TB cases to local public authorities for public health action. With these words, I would like to thank you. Thank you so much.
Thank you, Dr. G.V. Singh. It was a very nice and very exhaustive talk, and we'd be happier to hear you offline in an IACM Agra meeting. It was a wonderful talk. Very nice. Any questions?
So I've got one question. Dr. Shibendu from Calcutta. Can I make a question?
Come on.
Yes, sir, you are audible. Please go ahead.
Dr. Shubhendu, you're welcome to ask any question. It seems there's some internet problem.
No, can you hear now? Hello, can you hear me now?
Just one minute.
Yes.
Can you hear me now?
Yeah.
Yes.
Dr. Siramoni. Dr.
Yes,
Siramoni, am I audible?
Yes.
Yes.
Come on,
so,
welcome.
A good number. Yes, thank you very much. Thank you. Thank you all, Dr. Palik and others. Good, nice lecture. A large number of patients of tuberculosis is INH resistant. Knowing that, should we treat the patient for prophylaxis with INH only?
Very important questions, sir. Very important questions. So in national policy, there is a strategy that before starting the tuberculosis preventive therapy for isoniazid, the first and foremost thing is to rule out active tuberculosis. Okay. So diagnosing to rule out the pulmonary active TB is very, very important. So this is the at present the strategy. So there are certain studies. There is definitely the apprehension of the emergence of the drug resistance by giving the single drug, but there are number of studies that suggest there is no extra increase in the incidence of drug resistance by giving the extra the tuberculosis preventive therapy in various states and various other countries also.
Just 1 minute.
Dr. Sachan wants to ask a question. Welcome, sir. Dr. Sachan, please.
Addisonian crisis is one problem
Yes.
which we many times face. And adrenal tuberculosis presents with hypotension, hyponatremia, and low serum cortisol levels. Along with the evidence of tuberculosis, with all other parameters, adrenal tuberculosis has to be considered. In these cases, apart from chemotherapy, corticosteroids are very much indicated. In renal tuberculosis, problem even in heel disease goes on for frequency of micturition and the capacity of the urinary bladder sometimes goes on decreasing and ultimately lands to a thimble bladder. These problems are also amenable to surgical management rather than only medical.
Thank you, sir. Thank you for your observation. We are enlightened by your views. Any more questions?
Yes, sir. I have another question. If you have after ceremony,
Yes.
can you hear me?
Identify yourself, sir.
Dr.
Shivendu.
Shivendu from Calcutta. Actually,
yeah, welcome. Come on.
Yeah. So there are some of the patients, particularly pneumonia, the plenty of antibiotics nowadays, and ampicillin, even for quinolones, even our.
Your voice is cracking. You are not clearly audible.
Yeah. Interruption. There's a lot of interruption in your voice. There's an internet problem.
Hello. Hello.
So
Try
you
again.
can put your question in the chat box also. We'll read it to the concerned person and he'll answer that.
I'm sorry, all the time there is some unstable, connection. Now, can I question it now?
Yes, sir, you are clearly audible now. Please go ahead, sir.
Yeah. So, a large number of antibiotics which is being used for treating of, pulmonary infection, pneumonias even. There is a very good anti-tubercular drug that is proven, particularly now ampicillin, macrolide, azithromycin, aminoglycosides, and many. So if we suspect in a patient of tuberculosis, having a tubercular pneumonia like this, what drugs we should spare for treating the tuberculosis or diagnosis tuberculosis? Am I eligible for my question?
Yeah.
Yeah.
Very important question. As far as the current scenario is concerned, in our day-to-day practice, we usually see there's lots of antibiotics, those which are also the anti-TB effect, is being used to treat simple infections. And whenever, as you said, that there is a pneumonia, and first thing what I can say, it's if there is a pneumonia, any abnormality in the chest X-ray is a some के pulmonary TB. So you have to test for TB test also. This is the most important thing. And second important part is that which drugs should be spared. Definitely the fluoroquinolones, either they are the ciprofloxacin, ofloxacin, moxifloxacin, even the linezolid. Linezolid is drug. Amikacin, these are anti-TB drugs. Coamoxiclav, these are anti-TB drugs. They have anti-TB effect. So these are the drugs which should ideally be, should not be prescribed without confirming that your case is not a case, is a case of tuberculosis. Once you are confirmed, you are well confident that your case is not a TB case, then you can prescribe these drugs. Otherwise, these fluoroquinolones, and aminoglycosides, especially amikacin, streptomycin, they should not be used to treat the common respiratory infections. From my side, I can say.
Hello. Sir.
Very nicely answered. And now
Yes.
we are already we have crossed the
9:30.
timeline,
Yes.
and it's
Okay.
already 9:35. So let us now conclude the session. And for that, I request our coordinator, Dr. MP Singh, to do the needful.
Before I give a formal vote of thanks, I would request our President, Dr. H.S. Pathak sir, to say a few words if he wants to say.
Really, I'm very sorry. I was at a place where there was no internet connection, very disturbing, and I really feel very bad for this maddened CME in my tenure. So I thank all the chairpersons, all the speakers for a very nice presentation, and I must thank Dr. MP Singh for taking all the initiative from the very beginning, and he's continuing all these CME programs with very interesting and very useful topics. So over to Dr. MP Singh for vote of thanks and other things.
Thank you, sir. Thank you, everyone, sparing your valuable time on a cold winter night. I would especially like to thank our speakers, Dr. Sanjeev Sinha, sir, who is still in his office in Ames, has not got back home because of the CME. Thank you, sir, for sparing your time. It was an honor to have you with us. Dr. G.V. Singh, sir, professor, he spared a lot of valuable time, gave an excellent lecture. We'd certainly like to hear you both on a offline platform also, maybe in the next conference or in the next CME of IACM. The guest of honor, Dr. Parikh sir, who's the man behind this show. It is his inspiration, guidance, who constantly guides me and motivates me to conduct these CMEs regularly. Our chairpersons who took out time and conducted the proceedings. Professor Stan sir, it was an honor to have you with us. We'd like to have you with us in all our next CMEs. You are actually a blessing to this IACM with your experience and expertise. All the delegates who are there who have attended this, thank you very much. Hope to see you in the next CME. Bye. Good night.
Thank you. Good night.
Good night.
Good night.
Thank
Good
you.
night, everybody. Thank you very, very much.
Yes. Dr. Siromani, I can still remember your signature. Very good signature. Thank you. Okay.
Only the signatures are good and nothing else.
No, sir. Your signature is memorable. That much I can say. Other things are always memorable, but your signature
Thank you very much for appreciating my signature.
Okay.